Sebastian Denison is a clinical consultant pharmacist at PCCA. In addition, he also helps teach compounding pharmacists in the US and Canada. And in Canada in 2010, he managed pharmacy operations for the Vancouver Winter Olympics. So that gives you a little bit of background about him. He speaks to physician and pharmacist groups around the world. I think you'll soon see why he's considered such an expert. Mr. Sebastian, this is all yours, sir.
Thanks, Terry. Welcome on a Saturday. This is going to be a fun one. I think we'll start there. I do appreciate that everyone's still hanging in, and I know that there's a lot of questions, and oh man, there's a lot of good information being shared already. So hopefully I have something to add to the conversation. Hopefully some things that you haven't seen before. So I just want to make sure that everyone can hear me and that you can see my screen. So I tend to move around a little bit. So hopefully you can focus on the slides and we'll start there. I have to kind of give you a little bit of background. I started back in compounding pharmacy in 1999, and we actually were doing low-dose naltrexone way back in the day. And we were doing it basically for fibromyalgia patients and MS patients. And I actually asked that question right when I first started doing this. How does this work? And the resounding answer is, we don't know. That was it. We don't know. But when we do know, what we will find is that it's going to be really interesting, and it's probably something that it's unexpected. And so through school, and this is kind of an odd one, I actually did a background in immunology first before coming into pharmacy. And so kind of watching where the utilization was coming for low-dose naltrexone really took a turn for me in 2014. And this is about the same time that Jack started taking it. It's kind of interesting. I heard him saying he's been taking it for about 6.5 years. And we saw this shift in about 2012 where more and more people were starting to take it for more and more uses. So back in 1999, it was mainly fibromyalgia and MS. But what we did notice back then in those patient populations is they had incredibly sensitive guts. And that was the most funny part when I think about it now, is that they would all be super sensitive to the different type of fillers that we would put in there, but they all got better with their stomach over about 3 months. So after 3 months of use, they'd come back and they'd be like, yeah, my tummy's much better. You guys are doing your job well. And now in hindsight, it was the naltrexone was doing its job to the point where now people were getting healthier, and we just didn't know how much we were treating them. So kind of hindsight is 2020, but very interesting when I think back to it today. So, but I was asked to kind of wrap up this entire presentation because where we're going now is kind of the frontier where we're still just learning therapeutics and understanding. So I'm going to jump into some therapeutics that we've discovered and extend what Dr. Monaco was already talking about with respect to those pattern recognition receptors. And then hoping you start to see some pretty significant patterns in our current healthcare system, and then how we can actually use it moving forward in larger and larger patient groups. The dosing I'm going to leave till the very end, and I'm going to talk our standard dosing, but some of the dosing that we're starting to really see spin out are exactly like we've heard. Twice a day dosing, morning dosing, very low dose, ultra low dose. What works for the patient is probably the key piece, and finding that requires that input or that collaborative approach of an awesome pharmacy like Terry and his team. So when I kind of jump into this, please don't hesitate to ask questions. We've got a ton of time here, and I am pretty excited about this because this is where my first degree and my second degree really collided. And this is why I get even more excited about low-dose naltrexone every day, because we're starting to see the information that rolls out is the benefit in the immune system. And it's not just a single trick pony. Low-dose naltrexone is incredibly diverse in its functionality. So I am going to start off with a simple slide, because this is actually going to speak exactly what Dr. Monaco was saying right off of the hop. The evidence-based model is really tough today because there seems to be this incredible fight about making sure that the best evidence is heard as the only type of evidence that's acceptable is these large randomized double-blind and placebo-controlled multi-center trials. Well, where that becomes a real big problem is there's a significant amount of bias in these, mainly because we know that they cost close to $300 million for these studies. And unless there's a patent or a patent use behind it, we're not going to see a lot of effort going into these drugs. And so right now with low-dose naltrexone, there is no patent, and it's largely in the hands of compounding pharmacies. So the evidence that we're using is still the best evidence that's available. And what we're finding is that we're getting a lot more case reports, and we're getting a lot more physician-sponsored studies, case studies, small trials, and that evidence is mounting. And so if you want to see some of the more interesting stuff, that's where I'm going to jump in and point to it. But also what we're starting to see is also this sort of growing non-biased approach where it's, this is my group of patients and we're treating everyone, and look, here's the information and this is how they're getting better and these are the shortcomings. So the other part about the evidence-based model, and I always talk about this because I started learning about this back in from McMaster University back in the mid-90s, was it wasn't just about the evidence. It also had a lot to do with the patient values and patient preferences, as well as the clinical expertise of our practitioners. And we cannot ignore those two pieces because patient autonomy, patient preference, patient values also play in. Is they can actually be pretty strong in some of their positions. We can't just stand above them and tell them what to do anymore. There's too much pushback, and we all see that. And then, of course, we're seeing so many interesting evolutions in the clinical world that more and more clinicians are starting to say, this is what works in my group, and we're safe, and we are getting patient outcomes that are appreciated. And we know that clinical expertise can be very influential in this world. So as you have questions, please refer back to the different clinicians in this group that are actually already using low-dose naltrexone and talk amongst yourselves and find out who's doing what and what's working and what works best. That's going to be my comment, is what works best for that patient. It's going to be a yes, not a, well, this will work. No. Let's find out what works for them and let's make sure they stay healthy. So now we've all been talking about naltrexone and the different pieces, and I know there's been a huge discussion about the opioid growth factor receptor and the release of endogenous enkephalins and endorphins. But it's also really important to know that that system actually has other effects in the body. So we know that naltrexone works in the mu, kappa, and delta receptors, and we know that these can displace the opioids right out of these receptors. In fact, incredibly effective competitive agonists to those same ones. But we also know that by putting the key in the lock and we turn it one way, we get one response, and if we put it in the other key and we turn it the other way, this is kind of the cool part about naltrexone, is we know where it goes and we know what it does, and we know that if it turns the key, turns the key this way, opioids, and we turn it back the other way, what kind of immunomodulatory effects are we having? The reason that I say that is because we know that a lot of opioids actually have very distinct immunomodulatory properties themselves. More so, and this is where the dorkiness really comes out from the pharmacy side of the world, immunologically, and this is the immunologist, is we know that there can be pretty significant immunosuppression as well as this decrease in adaptive response by high-dose opioids in patients. And when I say, does this really occur? We've seen in geriatric patients, there's actually, we get this all of the time in the drug world. We actually get notifications that high-dose opioids, chronic use opioids can actually lead to significant infections in this patient group. We can see immunosuppression to the point where we can see hospitalizations can occur because of this sort of strong inability to mount an immune response to infections. So it goes hand in hand, and we see this a lot now in hospital settings where the patients will be evaluated and being able to mount an appropriate immune response based upon their opioid doses. So we're seeing this across Canada. I know it's happening down in the States. So how is it working? If we know that we're doing too much with opioids, well, what is the exact opposite response? Well, would we have immunoactivation or a better adaptive response? And that's something that we have to ask as pharmacists as well as clinicians. So now I do want to kind of point to a couple of things, and I'm going to kind of devolve into some of Linda's talk, and I'm going to follow up, but I'm going to bring a lot more immunology into this discussion, mainly because that's my background. That's also a passion. That's also where this functionality comes from. So we do know that inflammation and chronic disease goes hand in hand. There's actually a ton of articles, but this one in the Frontiers of Immunology from 2019 shows that you can actually see a lot of this sort of dysfunction can lead to chronic health problems and tissue damage. Now we're really seeing it in response to inflammatory cytokine cascades where we can see them uncontrolled. This is actually one of the hallmarks of COVID, is this cytokine storm. And now we're starting to see this sort of protracted lung disease as a result of this high inflammatory response. Why is that important to understand? Well, because we're going to probably see a lot more of these diseases as they crop up with more and more inflammatory issues. Now, specifically, I want to talk about these pattern recognition receptors that Jack was talking about. And these are the toll-like receptors. And there's actually quite a number in the body. There's more than just 4. In fact, there's close to 16 separate ones, more being identified all the time. But the common ones that we see across different animal species are also important, because how do we can actually learn a lot from some of the animal models that we currently have that have similar TLR receptors in their family. Now the TLR4, and the reason that I'm talking about this one specifically is because this is one of the key mediator ones between an inflammatory response and the so innate and the adaptive response. And so why is this so important is this receptor is one of the ones that says, hey, inflammation, inflammation, inflammation. And when this receptor is activated by lipopolysaccharides from bacterial infections and components, that's how we have this broad amplification in inflammatory response. And so this particular one is found throughout the entire system in all mammals. Now, when I say all systems, I'm going to come to the number of receptors where you find them in just a moment. But the modulation of the TLR4 pathway is so crucial to that inflammatory step that this is actually a major target for a lot of research going on in the drug world today. In fact, this is where a lot of biological effort is going, is because how do we manipulate the TLR4? How do we manipulate any of the TLRs is big, but the TLR4 is possibly one of the biggest, largest scopes in the drug world today. Now, the TLR9s is another group where we find that they're actually in this innate response, and they can actually have a pretty significant response when they're activated. And these are found in the B lymphocytes, monocytes, natural killer cells, as well as up in the skin, the keratinocytes, the melanocytes, and then of course in the variable, then we can see them expressed in cancer lines. And so these two specific pattern recognition receptors in your immune system that are so important into cell signaling and activation and amplification, not just activation, can be significantly important in disease states and disease progression. Now, why am I talking about those two? Because these are the two that are both quite well downregulated and modulated by low-dose naltrexone. Now, back in 2014, there was a specific paper, and Dr. Monaco talked about the dextro and levo response of naltrexone having these differential effects. Now, there was a paper that was published in 2014 where they talked about the levo and the dextro naltrexone, specifically the right and the left hand, saying that they both had a response in the TLR4 receptor. And why that paper is so important is they're trying to actually patent out the dextro only because it doesn't have any effect in the opioid receptors. It's the wrong hand. It doesn't fit in the receptor. The left-handed one fits in the opioid receptor, and that's where you get the negative response of naltrexone in the racemic mixture in these patients. The dextro only works in the TLRs. Why is that important? Because that's going to be the patent future, and this is what we were talking about with TLR4 and TLR9 activation and research. So don't be surprised if you hear about dextro naltrexone. There is no current source because it's actually being under investigation for figuring out how to separate out the racemic mixture. So the dextro is the one that people are going to be researching, but currently we have both versions, and this is the racemic mixture. Now, why is that important? Is because it is a pattern recognition. Now, these particular receptors, something like this they look like a T. They fold around the drug, and this is what causes this downregulation. And so this immunomodulation. It's not a suppression effect. And that is key to understanding how we can still have an adaptive immune response as well as a functional immune system, as opposed to the use of corticosteroids or immunosuppressants. those will literally just shut down immune system function. But because we're just shutting down the specific cellular response, doesn't mean we take away drivers, doesn't mean we take away any sort of buildup of drivers, and it certainly doesn't mean that we're going to control it for long, because at some point, life always finds a way, and you will see the subversion of systems. This is why we see corticosteroids fail after a period of time in the skin, or over time when they're being given even to patients topically, even orally, and we just see them run out. Same with NSAIDs. Eventually the inflammatory response overwhelms because there's still an ongoing building of the drivers, so the immune system will still function. Now with naltrexone, using the TLR4 and TLR9, you are modulating the amplification of the signal, and you can actually help address some of the underlying problems for these patients, because we get rid of the inflammatory response. We're taking away that amplification of multiple cytokines. Now all of a sudden we're taking away the drivers. Now all of a sudden we're helping the patients get healthy. Phew, that was a lot of information in 2 short slides. Now I am going to go back, and everything I talk about does have some evidence to support the statements, because I'm not smart enough to have a PhD. But it is important to notice that the TLRs are not just what I say, like, oh yeah, this is a really important one. No, the TLRs are actually being seen throughout the entire body, and they actually have different functionalities depending upon the tissue bed that they're in. So in the GI tract, you can actually see different expressions and different functionality of in those different cell lines. Same with the microglia, same with the dendritic plasma cells. You'll see it in keratinocytes. The different TLRs have different responses, but they'll all have similar functionality. Now, for example, in nerve tissue, I can tell you that TLR3s are extremely aggressive and cause this very strong immunomodulatory inflammatory response. TLR4s, when we use naltrexone, can downregulate TLR3 activity and actually cause a preservation of nerve tissue. Why do we talk about that one? I'm going to come back to it, is because number one, you can actually have nerve damage. You can have nerve regeneration with response to the utilization of naltrexone. And we've seen that, and I will talk about it. I promise I will come back to it. But it is important to see how autoimmune systems develop. And why I'm going to talk about this one is because, again, immune system function, the naltrexone, and then the TLR4 overlap. We do know that almost all autoimmune disorders are inflammatory in nature, and we see the same patterning of cytokines. So excessive cytokines, TNF-alpha, IL-6, IL-1 beta, IL-8 are often found. You'll see this over and over: Alzheimer's disease, Parkinson's disease, ALS, MS, schizophrenia. You'll see this overexpression of these inflammatory cytokines. And so knowing that this is occurring, we should be looking at, well, where's the driver coming from? What's the cause? Why are we having so much inflammation? And how do we downregulate it? And how do we address it? Dr. Monaco was talking about the gut being the center of this, but there's a little bit more information that I'm going to dive into and have some fun with. So, but again, this is what I was saying with the uncontrolled inflammation. And we all know this because we're seeing this more and more. Cardiovascular disease, the elevated CRP, the elevated ESR, they can be actually related back to different disease states. You can actually see the overlap between atherosclerosis, cardiovascular disease, and psoriasis now. And it's all with this high inflammatory response and this activation of white blood cells in the tissue. It goes on, you can actually see in chronic psoriasis, elevated CRP, elevated ESR, and you'll see it squirting out in different places. In fact, I think Dr. Monaco may have mentioned it, but when we talk about FAARM, they always talk about unhealthy gut, unhealthy skin. And so you can see what's happening in the gut, right in the skin, because if you see inflamed skin or this chronic inflammatory issue or disease in the skin, it can actually be sometimes tied quickly back to the gut. Now, cytokines and autoimmune disorders, and I'm going to talk about these ones very quickly because I do want to get onto the more important part. IL-1 is an important mediator of inflammation, but we see IL-1 A and B. Now, and I'm kind of going to go quickly through these ones. The balance of the two is important to understanding the pathophysiology of disease, and I'm not going to go too much deeper because that's like a 3-day course lecture, but we do see this also with IL-6. We see increased levels of IL-6 in so many disease states: rheumatoid arthritis, chronic juvenile arthritis, osteoporosis, psoriasis. We see IL-12, IL-17, IL-18 in the psoriasis patients. We see interleukin-17 in just more and more inflammatory diseases. And the list is endless. But where it got really interesting to me was this paper that we saw in 2017, where they tested, actually they looked at over 22 different cytokines. These 17 were reduced in 8 weeks. And if we look, you'll see that they overlap significantly. In fact, I put this slide together because I wanted to show you the autoimmune pathophys, not a specific single disease, but autoimmune pathophysiology has these similar overlapping increased levels of these cytokines. So the interferons, the tumor growth factor, tumor necrosis factor, activated NF-kappa beta, IL-1, IL-2, IL-4, IL-6, 8, 10, 17, 16. It just goes on, as well as that elevated CRP and erythrocyte sedimentation rate. With LDN treatment, we saw a reduction in these 17 inflammatory cytokines in 8 weeks. And that's the pattern. That's the slide right there. Is if you look at almost all of these disease states with chronic inflammation as one of the root causes, you will see that these same inflammatory cytokines keep appearing. In fact, you can test for them pretty easily, and then you can see a reduction in roughly 8 weeks of low-dose naltrexone. Now, we understand that the link is mainly related to the TLRs because they are the signaling linchpin across multiple disease states, not one. And this is why I'm not talking about a single disease state. I'm talking about all of these disease states. And when I tell people that, they kind of look at me and they're like, are you sure? And you can literally go through them one by one by one, and they all point back to the same issue. Uncontrolled inflammation, with the driver being something, but going through the same signaling pathway. Now, these endogenous or exogenous ligands can cause this initiation and activation, but it's the dysfunction of the TLRs and the dysfunctional amplification that becomes really problematic in all of these patients. So this particular paper back in 2018 actually talks about it being an immunomodulator, not a suppressant, not and not knocking out the system and preventing it from functioning, but in resetting the dial to good. And that's how I like to think about it, is it's not designed to suppress, it's not designed to hobble, it's not going to knock out that we see with other drugs right now in the marketplace. It's literally there to just reset the dial to normal or good. In fact, if we use it in patients who are actually relatively healthy, we can actually reset it to excellent. Now, Dr. Monaco alluded to this. I know Linda has talked about this. Did you know that there's more than 200 different identified types of arthritis alone, which is effectively just inflammation in the joints? Can cause pain, stiffness, redness, lack of mobility, degradation of the tissue, or hypertrophy of the tissue. We see that osteoarthritis versus rheumatoid arthritis. Well, which one is it? Well, pretty much they both have similar hallmarks, except we see bone degradation versus excessive bone formation. We can actually see this in scarification around the tendons and joints and ligaments, and we can see that reduction in mobility. Ankylosing spondylosis, we can actually see that hypertrophy in bone tissue. In fact, it can start impinging on nerves. Now, specifically to arthritis, and this is going to blow your mind, the reason that I put this up here is Dr. Monaco talked about the cost of his biologics. Most of these biologics, and in fact, with no permanent cure of these disease, the goal of all of these drugs is to literally just decrease inflammation. That's it. And we're talking about $36.1 billion, billion with a B, and all they're trying to do is reduce inflammation with these high-cost drugs. Reduce pain, improve a person's overall function, prevent bone deformity, be it hypertrophy or degradation. That's it. And we know what these drugs are. In fact, we've got a whole list of them because we talk about DMARDs, we talk about anti-inflammatories, we talk about NSAIDs, we talk about corticosteroids. And that's the entire goal of these drugs. We see it actually it's not just arthritis, because in all these patients with arthritis, we see these other cardiovascular disorders, pulmonary fibrosis, lymphomas. We actually see all these other issues around these inflamed patients. Usually patients come to you because they have arthritis, not because they know that they've got a cardiovascular disease. Usually they're showing up with some other problem that's inflammatory mediated, and then you do a workup and you go, man, these patients are really sick. They have other issues. High blood pressure is usually one of the first signs that they're inflamed somewhere and we should be taking action. What do? We're just trying to control their blood pressure. We're not looking at their inflammatory issues. Pretty much all of them will see this like little meta-inflammation in the background. We'll see this small elevation of white blood cells. Nothing significant, nothing to say that they're sick, but it's there, and their C-reactive protein is already starting to populate up. And the trend is going in one direction, and you're like, well, we should keep an eye on it. I'm telling you, that should be the focus, not something to be kept in the background. Now, autoimmune disorders, we already talked about these. I'm bringing this one up again because it's the same inflammatory cytokines, and I actually wanted to bring you back and look at these ones in very specifically, because all autoimmune disorders have the same conditions. Rheumatoid arthritis, we can talk about this one particularly because the number of patients that you see with rheumatoid arthritis, in fact, rheumatoid arthritis patients are the #1 users of opioid drugs in America today. In fact, it's across all of North America. #1 use of opioid drugs is in arthritis patients. Pain and inflammation. We know that opioids actually can cause more inflammation. In fact, they can be a key mediator and driver of inflammatory cytokines because of their direct action. And so I was talking about the TLRs. Remember I said the TLR sits like this. It goes around the naltrexone. It has an immunomodulatory response. It's got the opioid receptor, again, that same functionality. Naltrexone sits in there one way, opioids sit in this way. Well, the TLRs wrap around opioids in the exact same function and the same functionality group, and they do the exact opposite. So instead of down-regulating or causing an immunomodulatory response and decreasing that inflammatory amplification, it'll actually drive it. In fact, opioids are known to be inflammatory drivers. It's well documented. There was a paper that was published in 2014 and republished in 2018 because it was so important, because it was also updated, that we know the actual link between opioids and inflammation is through the TLR4 receptor. Rheumatoid arthritis, we prescribed opioids, we make it worse. In fact, we make all arthritis worse with opioids. And it's actually one of the first drugs we give. Osteoarthritis, what do these people say? My knees hurt, I can't walk upstairs, can I have some T3s or some Percocets? What do? We start them off on a weak opioid. When it stops working or it gets worse, what do? We give them a different, stronger opioid. We're actually making the problem worse for them because we're giving it to them chronically. We know it's going to be an inflammatory driver. We're masking the pain, but we're actually making their problem worse. Sjogren's syndrome. In fact, this is an autoimmune condition, and you see an overlap with Sjogren's syndrome. Most patients will start complaining about some other issue, dry eye, dry mouth, inflammation in the joints, skin issues. Then you do your workup and then you're like, you actually have Sjogren's. Psoriatic arthritis. Oops, here we go. They're all going to start falling under the same patterns, because what we see is that with psoriatic arthritis, and this is one of my favorite ones, is we say that this is like a distinct disease. It's this presentation of arthritis in the joints and in combination with skin. And everyone goes, oh, it's a distinct disease. It's the same pathophys underlying all of these patients. It's just the presentation is slightly different. All the inflammatory mediators are exactly the same. The standard of care is exactly the same. We start with an NSAID, then we go to a steroid, then we actually go to DMARDs, then we try biological agents. And this current standard of care is terrifying to me. The reason why is because I always look at the side effect profile of these drugs first. NSAIDs, we can actually talk about all of the side effects issues with the stomach. We cause this inability of it to repair. We can actually talk about GI bleeds. We can actually start talking about all the heart problems and kidney damage that we cause. But one of the other problems that we also see is this sort of suppression effect. And when the NSAID fails, what do we step to? Corticosteroids. Corticosteroids, thinning of bones, they stop the immune system from functioning, so we cannot repair at all. Weight gain, diabetes, they become more and more problematic because once they fail, we have to step to a stronger one. And when they fail, what do? We jump to a steroid, opioid type drug. Disease-modifying anti-rheumatic drugs, DMARDs. I'm surprised that we're actually allowed to use these drugs still today. The reason that I say that is because we are not allowed to work with them without a specific, and it's called the USB 800 type style room, where we have to be working under negative pressure because these drugs are so harmful to the workers. They're worried about the potential of harm when exposed to them inadvertently. One of the first ones out of the gate is methotrexate. In fact, we use this in oncology settings, and we're giving them to arthritis patients to control them, but we're not allowed to work with them. We're literally legally not allowed to work with them without a specialized containment field because of the potential harm. In fact, if you look at the blood work of methotrexate patients, you will see all sorts of weird data coming out of them. And then we get into the biological agents, which to me are probably some of the scariest drugs on the market today. Biological drugs, I'm going to bring you up to speed. This is sort of the fast, really early drug class that you'll probably have. The biological agents and how they work is they target, depending upon their specific monoclonal antibody, they're targeting either specific cytokines, receptors, or either one of those two. I'm going to come to the JAK inhibitors in just a second. And you'll see which ones they're targeting are going to be the common interleukins or TNF alpha family. Or they're looking at a specific receptor to shut it down or block the activity. Now, these particular drugs, when they wipe out that particular cytokine, take out a specific signaling cascade, which means that the adaptive response can be significantly functionally challenged. Now, this is one of my favorite ones. It's been studied, therefore it's safe. That's not the case. In fact, a lot of these FDA drugs that are granted approval aren't necessarily any safer than current drugs on the market and may not necessarily be any more effective, but they've been proven to be limited, they do have effect, obviously, but they may not necessarily be more effective than the current therapies. Specifically in some TNF alpha receptor blocker drugs, they actually had a study which was done in Canada where they showed that the rate of hospitalizations, side effects, and outcomes in the patient was no different than that of using corticosteroids, except the cost was significantly higher. We're talking about $4,800 to $6,500 a month versus couple of dollars. Literally, that's the difference. And no changes in hospitalization or outcomes in these patients. It just says symptomology is better controlled between hospitalizations. And what's scary to me about these particular biological drugs is we see increased rates of infection, increased rates of cancers, increased rates of uncommon infections or skin disruptions. And to me, this is a really scary one because when I've seen these aggressive cancers in these biologic patients, the time lapse between them being diagnosed with a cancer and being unfortunately passing away is significantly shortened, and there's not a chance for treatment options because they're so aggressive. This is the study I was talking about between 1995 and 2012, and we didn't see any sort of decrease that we were anticipating, and this was done over a number of years. For the JAK inhibitors, they actually target a specific receptor, which actually turns off the cytokine cascades. Again, we hobble the immune system so it can't actually function the way that we want it to. So again, same side effect profile of JAK inhibitors to that of the biologics. Increased risk of infection, aggressive cancers, and then now all of a sudden we're starting to see blood clots and cardiovascular issues. These ones can cause, they go after IL-6 specifically, but again, JAK inhibitors may not necessarily be any safer. They may not be any safer. And then a lot of people are saying that we're seeing these aggressive malignancies and blood clots. So this can be a problem unto itself because this drug that we're supposed to be giving to help these patients can become, in fact, quite harmful. Now, when it comes to all of these autoimmune disorders, we also see a lot of people talking about all the complementary medicine pieces. Now, when we're I do want to kind of step back and say everything that Dr. Monaco was talking about with the 4 R's of the gut. I know that we as pharmacists, we always talk about non-drug measures and health first: food, diet, exercise, nutrition, and supplementation. And I know that that's all being discussed as well. And I know that where that plays a role. When we're talking about naltrexone, we're not talking about complementary medicine. We're actually talking about medical drug medicine. And the evidence is there, but we do need to still keep these in the background. And this is why I wanted to touch on it, because for all autoimmune disorders, I agree with Jack that we still have to look at the gut first, supplementation, food choices, and making sure that they're still getting proper exercise and activity, and then making sure that they're getting the appropriate supplements and care there. Whew, I've been talking a lot and I'm kind of got excited about this, but low-dose naltrexone, I'm going to go back to the entire piece about safety first. This was a study that was done, and this was a retrospective analysis in 2019 where they looked at just over 11,000 patients, and this was an all-in. There was no exclusion criteria. This was all doses, all patient types, all disease states, and they were actually looking at the side effect profile. Now, Jack talked about it in his clinical experience in some of his patients, but I'm going to talk about it in an actual study, that they saw that there was no difference between this and placebo. And why is that so important is because the safety aspect of this drug is significantly better than most of the drugs that you're seeing that are being prescribed today for most of these autoimmune disorder patients. When we're talking about most of these autoimmune disorder patients, all of the biologicals, like there's ads on TV, Enbrel, Remicade, like they just go on. And you hear the side effect profile and it scares me. It's not something I would ever give to my child, or would not be something I'd ever want to be prescribed to my wife, let alone myself. When I talk about naltrexone, and we talk about naltrexone, this is the study that should be looked at first, is because we don't see a difference between it and placebo pill or sugar pills. The biggest one, the sleep disruptions. I didn't have a good night's sleep 2 nights ago, and I'm not taking naltrexone, but if I was, I'd be like, oh, well, it's the naltrexone. Was it really the naltrexone? Was it an increase in dreams? I do have a little bit of an interesting theory on that, but really and truly, it's changes in health, changes in immune cell function, changes in brain function. And it's not harmful, it's just a change, and these patients are perceiving it as negative. Now, when we do talk about naltrexone and does it work, you've heard from so many people about how much it works, but here's a study that actually shows in these persistent LDN users, they're seeing a reduction in all of those drugs that I've already talked about that were bad for them. NSAIDs, corticosteroids, DMARDs, and biologics. In fact, there's doctors here in Houston, Texas, sorry, I'm gonna be clear, I live in Houston right now. I'm in Sugar Land, and we butt up against Katy. We've got a GI doctor here in Katy, Texas, that's actually said that she's getting her biologic patients onto low-dose naltrexone and seeing a reduction in their frequency of dose. And in some cases, they're seeing patients discontinue their biologics because there's no need. And that's a pretty big statement, but there's literature supporting this. It's not just one person. It's not anecdotal. We're seeing this reduction in use of other drugs. We're seeing a reduction in the non-opioid family because we don't give it at the same time as opioids. Inflammatory bowel disease. In fact, Dr. Monaco was talking about one of these other studies. I've got 3 of them, and we saw the same thing. Ulcerative colitis, we see this Crohn's disease, this inflammation across the entire GI tract. And why is that so important is because of that sort of foundation of that gut being the health center for so many people. If we can start healing that intestinal lumen, we can actually see this decrease in inflammatory drivers. With specifically, we see the same, and I don't think I have to explain this to the prescribers, but we do see that increase in CRP, we see that increase in IL-1 beta, we see interleukin-6 as well as TNF alpha. In IBD, we see 2 different types of joint problems in association with Crohn's disease and irritable inflammatory bowel disease. So when we start seeing that decrease in inflammation in the GI tract, we start seeing a decrease in inflammation in joints. And I'm kind of jumping along here because there's so much information to share, but these 3 particular studies, 2007, 2011, 2013, we saw a rapid, we saw a very quick push towards decreasing inflammation and healing of the gut. We're talking 8 weeks to 12 weeks to 16 weeks. And in these patients who've been suffering for years and years, we're seeing such improvement in them with such a minor intervention that within 1 month, all patients were starting to see a response. Within 3 months, something like 93, and I'm just pointing to this, 89% of patients in 16 weeks were improved, and we actually see an induction of remission with LDN. This is a very similar picture to what Dr. Monaco showed. We saw 50% of patients achieve remission by 6 months. So this would actually preclude the need for other medications based upon your own criteria for ensuring that they're staying healthy and decreasing inflammation. Once we start doing this, we see all of the other health issues going away. When we're talking about with the inflammatory bowel disease, we see the intestinal lumen sitting like this. It's looking more like this. When we heal the intestinal lumen, it starts doing this, and we stop seeing the large proteinaceous molecules coming across, and we actually take away a majority of the drivers that cause the adaptive immune response to create an inflammatory background noise. And that's the key piece, is we're healing the gut, and we take away the driver for a majority of the other inflammatory aspects of their disease, because we're taking away that hyperporosity. And so even understanding just the Crohn's and inflammatory bowel disease gives credence to the rest of all other inflammatory diseases under the sun and autoimmune disorders. And that's why I was starting off here and getting very excited about all of this, is because we understand what we're trying to do with arthritis, autoimmune disorder patients, inflammation control, to control that inflammation. And so this is why we walk through in this step, is the guts is the foundation of that inflammation, as well as by controlling the gut and controlling the inflammatory issues, we actually start seeing resolution in all those inflammatory cytokines. Therefore, we're starting to remove the need for those other medications. And I am kind of, I know, very excited. Okay, I'm going to just set for a second. And this is how we're going to tie it together, because I know Jack was talking about this as well. And this is where I was trying to get to. We understand that most people start with inflammation in the gut, and that inflammation in the gut can lead to that hyperporosity. And this is where the trifecta comes, is our patients who have increased GI permeability, as well as a low biodiversity in their gut, a low biodiversity in their microbiome, will actually be set up for a majority of our autoimmune disorder patients. And it literally, it sets them up. And we see this time and time and time again. Most of the autoimmune disorders, and I list them off to the right, and this is a percentage, are effectively going to be tied back over the next few years to these same issues that we see. And so this trifecta is high absorption of bacterial proteins, increased GI permeability, inflamed and porous. So going back to patients who have significant gut issues, long-term use of antibacterials, low microbiome diversity, and then finally a high stress event. And the reason that I'm going to tie this all together is because when we start looking backwards at how LDN works, so decreasing inflammation, working well in the intestinal lumen, working with these TLR4s, mediating the inflammatory cascade and stopping that hyperactivity, we can actually start working our way backwards, and we can actually start helping prevent the onset of some of these issues for these patients, or patients that are already diagnosed. We will mediate a lot of their drivers, so we can actually start not inducing remission, but we can control a majority of their symptoms through these steps and through this kind of reversal of this trifecta. So again, the autoimmune disorder patients, it's demonstrated dysbiosis. When we talk about the microbiome, we actually talk about this low biodiversity, and we talk about these same patients having very specific gut bacteria pathogens. And where this is coming from is I got really excited about this probably back in 2017, 2018, after I'd finished the majority of the fellowship, and they'd been talking about all of the issues with the gut health. And I saw a really interesting little paper, and this is one of them, but they actually started talking about specifically the direct connection between specific gut bacteria, dysbiosis, and autoimmune disorders. And the link was patients with autoimmune disorders have low microbiome biodiversity. And there's specific gut bacteria that we keep seeing over and over and over. And in my immune brain, I went, hang on a second, it's usually a hyperactivity of the immune system, which leads to it. And it's a hyperactivity of the processing of pathogenic material that looks similar to tissue that's already existing in the body. And we did see this mainly because of the bacterial fragilis being high in numbers in this low microbiome diversity. And we saw that 87% of almost all patients with autoimmune disorders were pushing into this sort of bacterial fragilis. And we see that with lower and lower, less and less bacteria in the gut biodiversity. We're pushing down towards 70 or less specific bacteria in the gut versus a healthy gut of 140. We saw this high number of patients with bacterial fragilis. And the more often you see this, the more likely you're to start seeing inflammatory issues. And we started seeing a breach in the intestinal mucosa specific with these bacterial fragilis. We also saw this particular protein from bacterial fragilis, and it was called ubiquitin, was very well recognized by our immune cells in our own immune system. And we would do this high processing of it in response to this high number of bacterial fragilis, low biodiversity, high porosity, and this ubiquitin looked very similar to tissue that already existed in our body. And this is where we saw this molecular mimicry starting to trigger these autoimmune disorders. And people talk about familial activity, genetics, and I talk about, well, if you're living in the same house, you're going to have a very similar microbiome. You're going to eat the same foods, you're going to act the same way, you're going to have similar health patterns, and you're going to go through the same stress triggers. So you're going to see a very strong familial pattern in these autoimmune patients, mainly because of some of these other pieces. And I'm tying it back specifically to the gut bacteria and the activity in the gut, because we can actually start to see that if you have one autoimmune patient in a family, maybe you should start looking at the rest of the family. Now, this other bacteria, this was a very cool paper in 2018, was another piece to the puzzle. So this Enterococcus galernum was found to be a trigger in the gut, in the liver as well, and other it actually was throwing off proteins that caused a similar autoimmune trigger response. And so we see the Enterococcus galernum also being present in most of these autoimmune disorder patients. And I'm kind of like, I'm good. I'm trying to keep all of this information very tight because there's so much floating around inside my head. If you think about that intestinal lumen, and you've only got 2 or 3, well, okay, you've got probably 60 or 70 different bacteria, but in your high inflammatory gut lining in specific areas, you've only got 2 or 3 different gut bacteria that are being that are coming through and shedding protein, and you've got a large number of that protein being produced. Your chances of starting to see this onset becomes more and more common. And we're starting to see more and more papers starting to evaluate these microbial shifts. And this alteration can be addressed by probiotics, prebiotics, huge diversity in food, and making sure that the patients are getting diverse food sources, lots of fruits and vegetables that are uncooked. And this we're starting to tie back to type 2 diabetes. We're starting to see it to cancers, cardiovascular disease. And it wasn't just me. This was back in 2017. This entire discussion was being kind of being fleshed out. But the addition of those 2 particular bacteria with the high processing of those particular proteins tied back to tissue kind of pulled it together for me. Now, the high stress event, somewhat similar to doing a presentation online, these high stress events have been tied back to almost 50% of all autoimmune disorders. They do talk about the unknown trigger factors, but we can see it being a physical or emotional event. And so we're seeing everything from divorce to money stress to exams to parental sickness to kid sickness. But more and more is that almost 80% of patients, when given enough time backwards, that they're saying like, yes, there was an emotional event. Now, this emotional event can also change immune processing in the body. What happens, and this is a really unique finding, is that the immune system, when under stress, will undergo a shift, and it'll go into a hyper processing shift, and will actually take things that are considered pathogenic and process them more quickly and more functionally and amplify that information. So your memory B cells will actually amplify under stress events and become more functional and highly process much more quickly to adapt to incoming pathogenic information. And so this is why high cortisol can be a problem for patients with high porous guts with the presence of this bacteria. Because of that high processing and that high efficiency of processing, they're more likely to process some of this ubiquitin or the Enterococcus galarnum bacterial components. And this is how they can set up more likely with an autoimmune disorder in relation to that stressful event. And that's how we're tying it together, is looking at high cortisol, high stress, low microbiome biodiversity, and then this hyperporous gut. And we're starting to see more patients are starting to complain of this because we're starting to see more activity of PTSD, but then we're able to tie these inflammatory disorders and these autoimmune disorders to PTSD patients specifically. This is a study that was done in 2018 where they actually looked at stress-related disorders to PTSD, and they said early stress onset, and look, we're seeing this high amplification of pro-inflammatory cytokines and high processing of bacteria. Individuals with PTSD or post-traumatic stress disorder or high stress events, we see this high increase in inflammatory cytokines and high processing. Again, we see it higher in women versus in men. And then we go back and then we see, again, PTSD, high interleukin-6, high L1 beta, high interferon gamma levels. And now we're starting to see this chronic inflammation tied to PTSD or high stress, even chronic stress. And so all of a sudden we're starting to tie together all these different fundamentals, not just a single action, not just a single cause. It's almost like this a constellation of issues. We're able to say, these are your patients that are going to be setting up for autoimmune disorders. Maybe we need to start looking at them before they get sick. And that's where I was kind of going with this entire talk is we know low-dose naltrexone works in these autoimmune patients and how we can affect so many positive changes in them when they are sick. Now what we're trying to say is maybe we should be identifying the patients who already are autoimmune disorder and looking at their families and also looking at people around them that may be at risk of developing autoimmune disorders, because we can actually fix that gut alone with low-dose naltrexone, dietary implications, as well as elimination of foods. Maybe we could prevent the onset of autoimmune disorders. And that's what I was trying to get to with this talk is we know we can have a positive benefit in autoimmune disorder patients. Do you think we could actually make the jump and prevent these patients from developing an autoimmune disorder if we can recognize the pattern in these patients prior to them presenting to you as being afflicted? And that's the question that I actually had for you. So this is the discussion about the inflammation and antigen processing. During inflammation, increased presentation of self-selected peptides has implication maintenance for the peripheral tolerance and autoimmunity. Again, this is the gut bacteria presenting and being highly processed and becoming more likely to trigger an autoimmune disorder. Again, this is the same information. It's just being vetted out. This was actually accessed back just in July of this year. I can't stress this enough. The immune system, more and more is coming back to the immune system. A lot of people try and silo out the different disease states and say, well, this is rheumatoid arthritis, and that's arthritis. Therefore, or sorry, psoriatic arthritis, or that's psoriasis. And we have to separate them out between different physicians. I think what we need to do is we need to start looking back to this and pulling in the immunology aspect and saying, functionally, it's an autoimmune disorder. Therefore, we have to look back. Again, we have to have all aspects of the team involved. We have to have a GI specialist. We have to have a social health, social workers, social help, psychiatry. We have to have nutritionists on board. We need to actually have health coaches on board because there's so much more around these patients. We can't just say it's this or it's just that. We actually have to have a whole functional team. All right, continuing on. Antigen processes. This is actually going back to that same paper, the antigenic mimicry of the ubiquinone, Bacteriophagilis ubiquinate. Why is that so important? Because we know that the food choices can actually limit the microbiome biodiversity, and we have to increase the food choices. This is where the nutritionist comes on board. Make sure lots of leafy green vegetables, probiotics, prebiotics, making sure that they're getting a lot of different food choices to make sure that that biodiversity stays high so we don't have a majority of bacterial fragilis in these patients. And when we say that 67% to 80% of all patients have this, if you limit the microbiome diversity, then all of a sudden you're seeing a higher and higher number of bacterial fragilis subspecies present in the gut. Hyperpermeability, we've already talked about this. Again, this is also part of Jack's discussion. Controlling that inflammation in the gut. If you have a patient who has Crohn's disease, you're kind of almost having the expectation of that they're going to have other inflammatory diseases along. That's where I was talking about atherosclerosis, cardiovascular disease, psoriasis. I guarantee you they've got an inflamed gut. If they're not already presenting with an inflammatory bowel disease, they should be checked and then recognized as most likely having inflammation in the gut. If you've got arthritis or if you have Sjogren's, they should be talking about gut. If vitiligo or Hashimoto's, they all present on top of each other. It's just the one that troubles the patient the most is the one that you're actually usually treating. And so they all come back to a similar root cause, which is inflamed gut, high stress event, poor microbiome diversity, and now they're inflamed, and now we're not treating their immune system. We're trying to mask this specific symptom that they're presenting with. And so I'm still going to say we have to treat the immune system. This is all about the leaky gut discussion. And now we go back to naltrexone, and it all runs through the TLR4s and TLR9s. And this is how naltrexone can work in more than autoimmune disorders and specific arthritis issues. I think today 140 to 160 different autoimmune disorders have been identified and recognized. Over 200 different types of arthritis, all inflammatory bowel disease issues, not just the autoimmune versions of these. Anything that is inflammatory, in fact, can actually be looked at and said, is this possible to treat with naltrexone, in the sense of we can see the same pattern going through all of these patients. Increased inflammatory cytokines, high gastrointestinal permeability, and usually some sort of inflammatory issue in some sort of joint or pain. We can also see high CRP, ESR, as well as usually the presentation of inflamed skin. Now, these go back, this is the entire discussion, this is how I'm tying it back together. And I said this, these TLR4 receptors are so well presented in the entire length of the intestinal epithelium that this should be the first step in recognizing and treating of your patients. I'm going to treat the gut. This is what Jack said. This is what we learned at FAARM. This is why almost all FAARM functional medicine doctors say treat the gut first, and now we're reaching for naltrexone. This isn't just treating the gut, this is preventing those autoimmune disorder patients from being set up in such a strong way. I also want to point out that mast cells, B lymphocytes, myeloid dendritic cells, neutrophils, and monocytes, and macrophages have TLR4 receptors on them. And if you go through, microglia are in the upper CNS, the monocytes, macrophages are through the entire vascular system. Mast cells are presenting in the skin and in the lungs. This is why we're actually now talking about the use of low-dose naltrexone to prevent the onset of the cytokine storm in COVID patients, which is being studied right now in New York. The outcome of that study hasn't been published. They're waiting until the patient is afflicted. I'm suggesting that patients may want to consider being on it before they're being afflicted with COVID, because it gives them a chance to control those immune cells before they become dysfunctional. The literature is there that talks about the cytokine storm as it related back to TLR4s. We saw it in SARS, we're seeing it in COVID, and we've seen it in other septic shock syndromes, is that cytokine storm is usually related back to TLR4 dysfunction and dysregulation, and the literature is there to support those statements. Again, I brought up this paper. This was back in 2017. Again, these are the same papers, and the reason that I'm hitting them on them again is it's not me who's saying this. This is the information that I found, and I'm trying it together, or trying to try it together. In fact, so much so that we're now seeing that your second largest detox organ, your skin, or second most important, we're seeing that so much inflammation is there as a result of sort of this presentation that we can actually now start treating skin disorders with low-dose naltrexone. Everything from systemic sclerosis, Hailey-Hailey disease, psoriasis. In fact, we are seeing patients with porokeratosis also having sort of a hyperdysfunction, atopic dermatitis. It goes on. And where it gets really interesting is that we've actually seen patients now presenting with psoriasis being treated with low-dose naltrexone orally, not topically. And what we're doing is we're fixing that intestinal lumen. We're also fixing a lot of the drivers of the inflammatory issues, and then we're settling down that presentation of IL-6 in the skin. And so this is where we're starting to see the utilization of low-dose naltrexone expand, is that people are starting to say, I don't know what else works, so let's give this a whirl. In fact, topical naltrexone inhibited IL-6 by up to 70% when applied topically onto psoriatic type tissue. This was done in a lab, so what we've seen in patients is we tried it in patients and we saw resolution in about 9 to 14 days topically. Patients who looked at it like they had had belt sanders applied to their hands, we saw them improve in 9 days. Same patient, that was in 9 days. We're starting to use it in patients for wound healing, where we're actually seeing improved wound healing in both diabetic and non-diabetics. We know that it's an inflammatory disorder. We know it's a dysfunctional immune system, usually related to either high sugars in type 2 diabetics or non-functional immune cells as a result of high blood sugars. And we looked, and we're finding that we can actually help it with preventing scars, because of that hypertrophic activity in scars is related again to a dysfunctional immune system. Hypertrophy is related to high inflammation during the wound in the initial stages. In fact, non-healing wounds as a result of sort of that cavitation between inflammation and healing. And when it backslides into that inflammatory disorder, we see tissue degradation. And so that's why the wounds aren't healing. Well, for scar prevention, this is actually a dermal fibroblast. This was actually published in 2011. And we noticed it when we published in 2020 that we were able to heal up surgical wounds within 2 months without a presentation of scars. In fact, we tried it in some other patients. This is lipoma surgery. This was done daily for this is 3 weeks post-surgery. This was being applied just twice a day with 1% naltrexone. Thyroidectomy, we actually had a patient who was presenting with a hypertrophic scar. We were able to reverse it in 10 to 14 days. Again, this is controlling the inflammatory process in the tissue with the use of direct application of naltrexone. So this was actually kind of a cool one. And I know I've been like, whoo, ha, 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 because there is so much information. But we do know that the entire process of dosing with oral low-dose naltrexone, could we use it for these patients who have skin disorders like wounds? Well, there's a number of things going on with these diabetic patients and non-healing wounds. We know that they're probably not getting control of their blood sugar. And yes, they probably have a poor GI functionality. And yes, they probably have low microbiome biodiversity. But we can help control them with oral naltrexone as well as topical naltrexone directly in their wounds. In fact, burn patients who had significant itch were given oral naltrexone to decrease itch, because we know that the contracture scars was a result of that scratching right over top of where they actually had their burn and where they were actually having their grafts. Increased scratch lead to increased inflammation. This has caused a hypertrophic contracture type scar. So use of oral low-dose naltrexone shouldn't be just for the patients who you're thinking, oh, this is an internal autoimmune disorder. This could be used for skin disorder patients, as well as wound patients, as well as burn patients, as well as itch patients. Anything that is inflammatory mediated, anything that has an inflammatory component should be looked at with low-dose naltrexone, even to the point where we're seeing patients who have some of these really weird disorders. Stiff person syndrome, they've been treating that. Patients with alopecia areata, autoimmune disorder patient, we're seeing hair growth in these patients. Patients who are, we're seeing patients with Sjogren's, we're getting return of the functionality of lacrimation. So I did want to talk about the return of neurological function. Patients with loss of smell due to chronic corticosteroids for chronic inflammatory sinusitis. We actually migrated them over to low-dose naltrexone. We were able to get them off of their corticosteroids, get a return of normal to functionalities to the tissue, and they got their return of smell within 3 weeks. Patients with herpes zoster, so post-herpetic neuralgia, we know that that's actually an increase in inflammatory cytokines all along the nerve tissue. In fact, this is what causes that tissue damage, is a hyperinflammatory response in trying to clear the virus. The use of low-dose naltrexone orally as well as topically, we're able to reduce that inflammation, take away a majority of the pain, and see a return of functionality of that nerve in shorter periods of time than when just treated with anti-inflammatories and pain management medication alone. Skin lesions, we've actually seen tissue, we've seen patients with salivary gland destruction through chemotherapy. They were given low-dose naltrexone in sublingual drops, and we saw a return of functionality of salivation and lacrimation of those patients. Finally, any of these patients with asthma, patients with reactive inflammatory bowel, inflammatory reactive airway disease, we're seeing a reduction in their exacerbations of asthma presentation. They still need their puffers, but they don't need them as much. And we actually see a resolution of the majority of those triggers for those patients. So when I'm saying all of this is, if you have a patient who's on a puffer, you have a patient who's on an NSAID, you have a patient who's on a chronic opioid, you should be looking at all those patients and saying, is there a role for low-dose naltrexone for these patients? If in doubt, pick up the phone and call Terry, and he will walk you through it. And we'll probably find a way that we can get these patients on low-dose naltrexone. Patients who are at risk of autoimmune disorders, not only with autoimmune disorders, should be looked at as patients who would be targets of low-dose naltrexone. I can tell you that if there's a patient out there who has 2 family members with an autoimmune disorder, I can tell you they're sharing their microbiome. They probably have similar stressful events, and I guarantee you their diet's similar. We're just waiting for them to have an autoimmune disorder. They should be considered as a candidate for preventative sort of step. Patients who have skin lesions or skin disorders, inflammatory skin issues, patients with wound issues, any of those patients, there's so much that is available to us with respect to low-dose naltrexone, mainly because of those 2 TLR4 and 9 receptor activation and adaptive response. In fact, we're starting to see the use of low-dose naltrexone in patients with chronic infections, because we can mount better adaptive responses to the point where we're starting to see the use in not only bacterial infections, we're using them in long-term chronic fungal infections, but now we're starting to use it in patients with HIV and other viral infections. In fact, that was studied back in the 90s, where patients were given low-dose naltrexone when they had HIV and they saw recovery of their white blood cells. Anytime you see these sort of viral infections that are chronic and long-lasting, they should be considered. And there's a whole discussion there. And then finally, when we're getting into cancers, we usually see a derailing of the immune system and either a subversion, so we're not even seeing an adaptive response, or we're seeing a hijack and it's just even hiding it completely. There's a number of patients, and we're actually seeing it mainly in the vet world, where they're giving low-dose naltrexone to dogs, and we're seeing palliative response anywhere from extension of life from 3 months out to a year in dogs who are considered terminal, and they're considered 2 to 3 weeks out. And we're giving it to human patients who have cancers, ovarian, breast, brain, And we're seeing changes in those patients. Pancreatic cancer patients are pushing out 5+ years of survivability, when we're talking about 3 months survivability in the majority of those patients. Ovarian cancer patients, we've had a number of those. Breast cancer patients, they're like, yep, low-dose naltrexone and all other therapies. Very limited side effect profile, very limited overlap with other drugs. The biggest one that we usually see is with our drug interactions are going to be the narcotics. And then this other drug for GI functionality, helping people process food. So if you actually give them naltrexone, they actually digest a lot better. We see that return of normal bowel function in most patients within a couple of weeks. And then again, the biggest one that I'm going to say is anywhere where there's pain control, there's other options for pain. I would rather see patients come off of these pain management medications and go to low-dose naltrexone and a ketamine response, because we can actually treat a lot better. And then finally, this is going to be the last part, is Jack talked about how cheap it is. I'm going to talk about how incredibly cheap it is. When you're talking about $4,800 a month with respect to these biologicals, and you're talking anywhere between $90 and $100 a month for naltrexone, to me, it's stunning that insurance companies haven't just turned around and said, yes, give the naltrexone. This is a much better choice. It's significantly cheaper for them. Yes, it's compounded and there can be a discussion. But again, this is why you want to work with Terry and his team, is because naltrexone is probably most important because of the concentration. You want to have the highest quality coming into it. And this is where I come in, is like when we talk about naltrexone, we used to crush tablets and we were like, yeah, it'll work. But it came along with a lot of other problems. And I've seen people come onto the market and they're trying to sell naltrexone, but we're seeing anywhere from 5 to 12% water content, and people aren't ingesting. We're seeing contaminants in there where patients are like, I'm not getting the response out of my naltrexone that I should. And we don't know why, but we do know that when Terry is treating his patients, he's working through us. And you always have to look at the highest quality chemicals is going to give the best outcome for the patient. So this is where it's so important for us to be involved as a company, is making sure that we're delivering the highest quality chemicals so that Terry can deliver the highest quality care to your patients. And this is a funny thing, and this is why Terry kind of also said, like, hey, do you want to come and chat? We have ultimate faith in the entire group at Madison Drugs, because we know they've been doing it for the longest time, and they can actually stand behind their clinical outcomes because based upon their choice in their providers. So anyways, I know that there's so much more that we do want to talk about. I kind of burst through that in a very short period of time because I've been studying this now since 1999. And the turn for me happened in 2014 when I saw those papers. I've been taking naltrexone myself, just like Dr. Monaco, for probably a good 6 months now. The biggest thing that I found for me was I saw a change in my sleep patterns. And I am going to talk about that really briefly, is my microglia started working better. So I was able to process out all the junk and all the funk much better. I had a few wild dreams for the first 3 or 4 nights, and then it went away. The more fragile your patients are, the more toxic they are, the more likely they are to suffer some of those vivid dreams, mainly because we're getting their microglia to function better. And if you're worried, I just put them into a daytime early dose, or even I split the dose down and I do that BID dosing early in the morning, 2 milligrams and 2 milligrams. Those patients do extremely well, plus you're giving them back their sleeps. And if they have good sleeps, they historically do better as patients. So on that note, working within this group, I know I give you a lot of information, but really the take-home message here is look for that inflammatory patient pattern. If you see that inflammation, chances are we can alleviate a lot of it or modulate a lot of it with low-dose naltrexone without having to reach something to just squish it down. And the difference there is we can actually see clinical outcomes where we're seeing patients who can thrive and not have to suffer ill effects of some of these other nasty medications. So on that note, I know that there's probably a few questions. Terry, I know that was a lot of information in such a short period of time. I did pack it full of a lot of slides. So
we appreciate that, absolutely. I know that my brain is full every time I hear you. My brain is full. Full to overflowing. I've got pages of notes here. I don't know that we have questions coming in from any of the attendees at this point in time, but this is so for first glimpse for someone, this may be just overwhelming because you have coached a lot, but that's what we need to hear. We need to understand the full extent of what this can do. One of the things I heard you say, I'm a little bit facetiously rephrasing this, but if you have a patient come in the office, why not LDN?
I'm going to say this a lot less facetiously is, how many patients are currently struggling with high stress events in what we've seen in the last 7 months in our entire world? How many patients are you seeing who have a bad diet, who are slightly overweight? How many have some sort of inflammation or complaining about some stiffness or some sort of issues that they can't really figure out, and no one's seeming to give them any answers? These are all of the patients that you should be looking at going, man, I could really possibly head off a huge health issue for them in the next 5 to 7 years if we just get them started. In fact, there was a paper published in 2009 and 2014 that talked about the hypothesis of use of LDN for long-term health consequences for these patients. Is if you've got a patient over the age of 45 who has any familial history of inflammatory diseases or chronic diseases, maybe they would be a good candidate for LDN to prevent disease. And people looked at that paper and they were like, that's insane. And I'm saying that paper was so insightful at the time, because literally the prevention of disease should be the goal of what we're talking about, not the treatment of disease after the fact.
Absolutely. Now, this is such a goal for something like this, is that ability to prevent. And so that seeing that transition showing up in the literature now is excellent, is wonderful. What we see, of course, in the marketplace is this whole spectrum of issues, from practitioners who've never heard of it, are still skeptical about it, to those who fully adopted it, like Dr. Monaco, Dr. Grana today, those who are now looking at it, as you mentioned, these papers as a preventive. I think I hope that we can see this movement, toward this prevention issue across the whole spectrum. But we're all trying to do our part, and that's what this today has been about, to hear you, to hear Dr. Monaco, Dr. Grana, to hear Linda, to see about the work that Linda's been doing for years and trying to spread information about LDN and make it more and more available to people around the world.
Well, Linda has been an advocate for so many, but now it's almost like that volume of information is finally catching up to what she's been saying for so long. And now there's not just this single voice. There's literally whole research groups that are going after this and saying, there's not only proof, like, let's validate this discussion, and so we can move forward and treat these patients with an effective, really cost-effective tool. And that's what Jack was saying, is how can it be so cheap and so useful? There's no patent. That's it. That's that simple, and it's in the hands of compounders.
Right, in the hands of compounders. But as you reinforced, and I mentioned earlier, be careful about what you get. One anecdotal story with that, in one of our classes for practitioners locally, we had presented some of the videos from one of the international conferences. We had discussion afterward. One of the practitioners said, well, I'm getting about a 50% response. Some of it's working, some seems not to. And we just said, where are they getting it filled? Said, I don't know, I'll check. And within about a month, we suddenly were getting about 3 times more prescriptions from that practice. So I think that was telling. Looks like we may have a question in the queue. Jenny, do you have something?
Yes, it looks like we do have a question, Sebastian, for you, and it's asking about someone who is taking 1.5 milligrams of LDN in the morning, but is still having pain in her hip and upper back. And it says, should I increase it until I am pain-free?
Well, I'm going to start off with what was the starting reason as to why they were using LDN. If you still have pain, you can safely increase, and that would be part of it, making sure that we still get some of that inflammation under control. Now, LDN is not historically a pain management drug, and we shouldn't be looking at that. What we're doing is removing a lot of the inflammatory drivers that will sensitize people to pain or be creating pain. Some of these patients, we can reduce a lot of those issues, but there may still be pain present. We may still have to use some other pain management drugs, but non-opioid versions, which is the goal of almost every prescriber that I know that goes with LDN. Is we don't want to touch opioids. The restrictions on opioids are over the top now. So the use of other pain management drugs, topical pain management, because we can put it right where we need it as opposed to going systemically. There's a lot of compounded options there. But yeah, at 1.5 in the morning, I would consider going up to a 2 or even a 2.5 for that patient, seeing how their pain is. They might see an increase in mobility, but again, you may still need a bit of pain management to control some of the pain that exists as a result of what was happening before. Me personally, I love magnesium, so that's where I'd start.
If that patient is having any side effects associated with their dose increase, would it be any advantage to split the dose for them?
So the literature that we're seeing is it is really a good idea to actually start splitting the dose. So they could do 1.5 in the morning, they could do, say, half in the afternoon, or they could, like 0.5 milligram in the afternoon, and then titrate that up to 1.5 in the afternoon as well. And I do really like that idea because, and I'm going to go back, and I remember when I had a little baby, my sleep was so disrupted that everything became a problem. It's like my hair hurt, it felt inflamed. And so the less sleep that you get, the more disrupted your sleep becomes, the more issues you'll have. In fact, there's a lot of literature that actually ties sleep pattern disruptions to increases in cortisol, changes in inflammatory cytokines, as well as changes in actual gut function, and sort of that you can actually see a decrease in microbiome as a result of chronic poor sleep. Because the first thing that you do is when you're tired and not sleeping and not resting and high cortisol, your food choices change like that. You'll actually go for highly processed, easy, cheap energy systems. And that usually is related to bad food choices. So your microbiome will take a hit as a result of poor sleep. I am going to stand firmly in the camp of make sure you protect your patient's sleep in all aspects. If they're talking about these side effects, switch them to morning, switch them to BID dosing, but protect their sleep first and foremost, because good sleeps is going to be equally important to their overall health.
Absolutely. So you mentioned magnesium. We probably have every patient through the door on magnesium already.
Yep.
So what other agents would you drop into that line if necessary when you're trying to support sleep?
Vitamin D, always, always, always.
Yes.
Vitamin D is probably one of the other biggest ones for immune system function. So vitamin D3, it's already activated. Most people don't have enough vitamin D, even down there in Alabama where you're getting lots and lots of sun. Most people who are working indoors, especially if they're sick or or if they have some sort of mobility issue, are not getting enough sunlight. Therefore, they're deficient in vitamin D. I could probably ask any other healthcare practitioner on here, can you pull a vitamin D level? And they'll be told, no, you can't because it's too expensive. Everyone's vitamin D deficient. Ding, ding. Your immune system is relying on vitamin D levels. So 5 to 10,000 every day.
Yeah.
Melatonin, in fact, for a lot of my patients that were having issues, I was actually making the recommendation of putting 3 milligrams of melatonin in with the Naltrexone capsule, along with backfilling it with magnesium. And the reason why is because you're taking it at bedtime, you're going to take your medication, I might as well help you sleep. Melatonin is also a very potent immunomodulator, and we're using that more and more and more. It's also going to have a decrease in inflammatory cytokines in the brain, so microglia, and you'll actually help induce a pattern of sleep for these patients. So good sleep, good health, good immune function, and then you can also throw some vitamin D in there with the magnesium. So that's my own personal one, was D, magnesium, melatonin in my capsule with my Naltrexone for those patients. That's always been a recommendation. I'm sure you've been following that one too. So, and that's how you get patients to sleep if they need sleep.
That's what I was fishing for, was your position on melatonin. Absolutely.
And a lot of people, and so I don't want to get too far down this path, but a lot of people ask about melatonin and the dose of melatonin. The use of melatonin is so contentious now, and people are like, well, what's the appropriate dose? Usually I try and get a patient to sleep, and then I back down from the dose as best as I can and get them down to where I've repatterned them to sleeping, and then wean them down to a point where they use the least amount possible. many patients, when you start fixing the gut, you'll actually start improving their serotonin levels, which will then improve their melatonin production.
Right.
But today, we already identified most of them have inflammatory bowel issues or some sort of issues with poor food choices and low microbiome biodiversity. Their serotonin production is in the toilet as well, so they're not going to have any melatonin. How much is enough? Did they sleep last night? No. Increase. There's a ton of literature out there where they're using melatonin in cancer patients, and they're using it in doses of upwards of 20 milligrams or more. So comfortably 3, 6, 9, 12, just to get them to sleep and then back down very rapidly. Works wonders. And then as we fix the gut, all of a sudden we preclude the need for melatonin for a lot of these patients until they're elderly, and then all of a sudden we might need a little bit more. But melatonin, naltrexone is a much better combination than, I don't know, narcotics and benzodiazepines. And when I say it that way, people are like, yeah, that's a good point. True story. Dispensing opioids is just like, here, we're going to make you sicker. Yes, we're going to solve your pain, but now we've got so much constipation and inflammation in the gut. Now they're reabsorbing more and more of the excretion matter, which is lipopolysaccharides of dead bacteria, along with toxins. And so we're just driving so much more inflammation, not from the actual mechanism of opioids in the receptors, but all of the byproducts of the side effects of opioids slowing down the entire GI system and causing constipation. So, and benzodiazepines is just like I'm the pharmacist, you're a pharmacist, anyone who's a healthcare practitioner, if you've ever given a benzodiazepine, you know they are addictive. There's nothing that is non-addictive about benzodiazepines, period. They're crazy drugs, so.
Sebastian, thank you. Excellent as usual.